I wish my mother were still alive, God bless her, to hear that introduction. Well, I appreciate that, and I have to thank the partnership with Gonzaga and the University of Washington to make this trip a real opportunity. It's coming from the Northeast. I was amazed when I drove across the country, the Mass Pike from Boston. There was still a traffic light somewhere in Idaho. And the bridge, I-90 bridge, still had a toll on it, so you can tell how long I've been around. And I fell in love with the western part of the state and only became more familiar with this lovely part of the state when I became a faculty member of the University of Washington, and our WWAMI partnership had me visiting regularly to meet our teachers and to educate our students that are here. And in fact, unfortunately for those who had lunch with us today, I took their appetite away because I made them learn a little basic pharmacology because in a few months they'll be taking the course, so they may have a leg up on that. So I'll be speaking today about the opiate crisis in Eastern Washington. How did we get here and what do we do now? And I'm a very optimistic person by nature, but I think I'm going to be able to share the fact that there is much happening and there's improvement ready to go, and it's very important that not only our future physicians, our students and our residents and our current folks in practice, but the community understands, because you're ultimately our customers taking care of you. So what I'll be talking about is, number one, how we got into this mess, the opiate crisis, what we in the medical profession and the healthcare systems need to do in order to respond, because if you don't have a workshop that functions well enough to take care of people with pain, you're not going to do it successfully. And how you, the public, the folks who may or may not have pain or have a contact with someone with pain can actually help. Because the expectations set for our trainees, expectations set for our practicing clinicians, and the expectations for our patients with pain. And if I ever say the word chronic pain patients, please heckle me, because that's a derogatory term. And we have to rethink the way we view this condition. So we're going to walk through some of the opioid conundrum, which is the main topic. Opioids, the joy plant, hugel was the Sumerian term for it, 5,000 BC, so 7,000 year history of human interaction with opioids. And my slides got squished in the conversion from a Mac to a PC, but this is the Ebers Papyrus in 1552 BC, which was extolling the benefits of this magical plant, which relieved suffering of all kinds. The syringe was introduced, for those in medical history, in the 18th century. 3 separate people, a veterinarian, a surgeon, and a pharmacist, effectively, introduced the syringe, which changed the ability to convert an oral product into an injectable product. And that more or less coincided with the first opiate epidemic in America, which is returning Civil War veterans who had become opiate dependent because the syringe allowed us to give massive doses to our combatants. And this is not dissimilar from our veterans who have, many 10 years ago, had an enormous opiate problem, and a great job by our U.S. Department of Defense and Veterans Administration for making a big change, and in fact are leading the country now in addressing this problem effectively. Interestingly also, and similar to the Civil War era, the scourge of the problems occurred in rural parts of the United States. Rural South had the biggest hits in terms of the populations of opiate-dependent individuals. And then we started to use it for children teething. It was over the counter, Miss Winslow's soothing syrup for everything your child could want. And there's a Googled version of morphine that was available over the counter. Heroin was prescribed as a balm for anything that ails. And until 1914, you could buy this stuff over the counter. And that was when opioids became a restricted drug. So jumping into the future, from Antiquity to the internet, this was a search I made a few months back. I can't attest to the products up here and the prices that you could purchase online
oxycodone, OxyContin, and certainly the illegal and illicit manufacture that's streaming in. You can purchase this stuff online. And this was a couple months, and we're still getting startup coupons to get our patients hooked on OxyContin because it's hard to afford that particular drug. So there's been a long history. So what are they? And I know this is not a scientific audience, so I'm going to try to keep it clear and understandable. So on the top of the slide, you can see a little lock and key. The molecule is the key, and the receptor is the lock, and it fits into the lock, and it fits. You can turn the key, and you activate the receptor. And the receptor is, a cartoon of that is on the right. There's two wings of the receptor, the mu for morphine, Greek for the M letter, and multiple pathways. And we won't quiz you on that. There's a couple of students that you'll get a quick quiz on the way out. But it has two pathways, one of which is clearly associated with analgesia. Another one of the pathways clearly associated with tolerance and the challenges that people have with the negative effects of the opioid molecule. We're still sorting that out as to what roles they play and how we can target more effectively. Opiates are derivatives of the of the natural plant, the naturally derived opium. And you can see heroin, morphine, hydrocodone, Vicodin, the #1 drug that's prescribed in America. Hydrocodone, more than any other pharmaceutical. It ranks #1, a bit of a problem, I would say, and hydromorphone. These are the characteristic drugs. And opioids subsumes not only the natural products, but the synthetic drugs. So the correct term is opioid, because you won't get it wrong, because you get capture the whole product. And there you can see the oxycodone products, fentanyl, methadone, tramadol, which is an opioid, not often recognized, and buprenorphine, which is used for many purposes, as is methadone, for both addiction management as well as an analgesic for pain. So what then is pain? My mentor, John Lozier, I'll quote him a few times, was one of the first disciples of John Bonica, who started pain as a science and as a clinical specialty in the world. 4 generations of pain specialists from around the world were trained at the University of Washington at the Medical Center. I'm one of them because I got trained there in 1980 when I was practicing general internal medicine and doling out opioids and had no idea what I was treating. It's still a bit of a problem because pain education needs to catch up to the rest of the curriculum in medical schools. But pain is, in the pink, it's an unpleasant sensation. It's associated with an experience, so it's not something we can get our hands around. It's with actual, so you either have a damage or danger signal alert, or the thought of that, and we'll talk a little bit about how that happens. Just thinking about pain makes you hurt. And if you think about pain and then get a pain sensation delivered, an experimental sensation, that pain sensation is worse by having thought about it. You can prime the pump by just thinking about it. So potential damage, and it's described as such. I guess a couple of people got stuck in traffic, so it was a pain in the neck to get through that. There was an article in one of your local journals today that was talking about pain. I can't remember the verbiage, and it had nothing to do with pain that I treat, obviously, as a pain specialist, but it's a lot about the pain that most of our doctors are treating, which is pain of breaking up with relationships and struggling with difficult family life. So we use the same words, and it turns out the systems in our brain share the same pathways. So our emotional systems and our pain systems, our social connection systems, they're all linked. We'll speak about that in just a moment. So nociception is the pain signal. Pain is not nociception because you can have stimulation from the periphery that's horrible and not have pain. Or you can have no sensation from the periphery and still experience pain. So it is the signal that does not have to represent pain, but the response to the human environment and what we think of it and what we make of it will change that into a more or less painful experience. Suffering is our response to the diminishment of our capacities. So children suffer when they don't get the toy they want. Young people suffer when someone breaks up with them on Twitter or Facebook. That's suffering because what they think they're going to become is not happening. Medical students get upset if they don't get a good grade in my class, and that's another version of suffering. And people with pain, when they feel like their life is ended and there's nothing else that they can do and there's no hope to ever get better, suffer also. So pain is not optional. If you don't have pain, you won't make it through adolescence, because pain is the alert to our body that there's a danger signal coming in. But suffering can be managed. And the medical profession, before the introduction of the sulfonamide antibiotics, seeing a physician didn't really make any difference at all. But the healing powers that we should be as clinicians to understand our patients and to carry them through the difficult times, that's called healing, and a lot of that can relieve suffering. We do it all the time, and we should appreciate that. And the behavior of what patients are showing us or what your family members are seeing, that's the visual expression to us of someone having pain. And in fact, if you're shown an image of someone in pain, your pain system activates in your brain. Functional MRI can show us that. And if you're showing an image of a family member who's having pain, it activates more. Nice science that's beginning to work out these particular pathways. And probably not surprising to any of you when I'm saying this, because you've all had this same experience. So why is pain so hard? For patients who really are the sufferers of this condition, and also the practitioners who are taking care of them. Because it's complicated. As I mentioned, it's a survival alert to danger and bodily damage. So it's got a real clear function. It's poorly understood. The science hasn't caught up that well, and we do a terrible job teaching our students. Veterinarians, God bless them, have 78 hours of pain education, and the average education of medical students in the United States is under 7 hours in pain. So we have to pick that up, and that's one of the reasons we're leading the country in the National Institutes of Health consortium of pain education, because we're leading the charge in improving their education. Collaboration and multidisciplinary care is part of it. So you have to have a care team. Working all by yourself, particularly in a rural area where you don't have a large staff and a lot of other specialists around to support you, makes it that much harder. So systems of care need to be able to integrate multiple different providers and practitioners while the care is delivered. Otherwise, it doesn't work that well. It also extends across the life continuum. So pain in a newborn is different than pain at 6 months, which is different than pain at 3 years, which is different than pain at 12 years. And through adolescence, the pain system begins to mature, and pain carries through the lifespan of an individual until the end of life, when care changes in terms of goals and expectations, and comfort matters more than function and advancement and moving forward in life. That's called palliative care experience. And it's also complicated because every individual experiences pain differently. They experience pain differently, genetic reasons. They experience pain differently based on their life experiences. I'll touch on that in just a moment. Things that happen to you as a child and as a young person will change the way your pain system is set in response to the same signal. And our job as clinicians taking care of this, and your job as family members and perhaps patient suffering with chronic pain, is to recognize that you are unique, and we have to recognize what makes you unique and differentiate you from a chronic pain patient. And like all things, socioeconomic disparities abound, which is good for people of color because they're less likely to be exposed to opioids, because we don't prescribe them opioids, because we don't trust them based on the color of their skin. So that's why white Americans are much more likely to be sucked up into this opioid epidemic than people of color. Not the right way to be able to accomplish that, but it changes our views of how healthcare is being delivered. It has a huge burden. Dennis Turk, part of our faculty, this is an old slide of his, it's still right, function, socioeconomic consequences, healthcare costs, lost productivity, disability, emotional function, marital, social interactions are all affected by having pain. It's not fun to have pain, and you get separated from your job, your family, and your social groups. And then you can't do things. Your sleep is wrecked, your work, your hobbies, all impaired. So it's a huge burden we have to recognize. And notice, nociception is not a factor. This is not a sensation. This is the social and psychological consequences, which is why pain is called a biopsychosocial model. That term was framed at University of Washington about 1965. So we've known this for quite a while. So let's take a brief history of understanding pain. Descartes, one of the earliest scientists, said, "Ouch, my foot's in the fire," and it was a pipe that signaled the pineal gland in the brain. It was bottom up, signal coming from the bottom, and it was a straightforward reflex. The question most people ask is, why is that boy's foot in the fire? But nonetheless, we can go past that. This dates to the 15th century. It's a manuscript from the Persian Empire. What's wrong with this picture? Is this guy hurting, or does this guy have meaning and purpose in his life to survive, and he's using his leg as a club? And so it's eye-catching, but this is normal. In fact, in 1942, Dr. Henry Beecher identified it on the Anzio Beach. The catastrophic, both sides of the war were slaughtered. Most of the soldiers who returned back with horrific casualties did not report pain, did not request pain relief for up to 48 to 72 hours. So we have remarkable abilities to control our response to that external sensation. And coming soon, we're going to have a lot of people in Bloomsday. This is last year's picture. I don't have this year's. These people are running marathons, and I've tried it once or twice, and I tell you, it hurts. But no one is complaining about pain because they have a goal, they have a purpose. They've worked hard to accomplish this, and the pain system can be shut down by redirecting the sensation. So the latest work is coming out of lots of research labs. Karen Davis in Toronto has done a great deal of work, and I want to call your attention to that little curled arrow in the right top corner. That's paying attention to pain. I alluded to that earlier. This is being asked on a 0 to 10 scale how much you hurt. You begin to pay attention to that, and you hurt more, which is why that 0 to 10 scale is probably not a good idea, and it's being removed from the Joint Commission, from the in-hospital, and I think I was on a call recently from the outpatient side as well as a mandatory request. So we had an under-treatment of pain where we needed to ask the question, and now we have an under-treatment of pain because we're using opioids, because opioids are not going to be the solution to such a complicated problem. The mind wandering, I'll get to this in a bit as well. Mind wandering is the meditative state. When you're sitting by the Spokane River, watching the water flow, birds are flying, you're at peace, restful. Your pain system goes to sleep. You're not feeling those negative sensations. This is why meditation and some of the other non-pharmacological strategies work so well. And on the right is what is called the descending inhibitory pathways, because that Cartesian view of pain going from the bottom up is balanced in a healthy human being by a shutdown of that pain signal from the top. If it's not important, if it's not salient, an important thing, the brain modulates that sensation down. Some people call it distraction. I call it the wonders of evolution, that we're able to escape predators or run marathons and not be blocked by a sensation that is less important than the task that you're actually doing. And this is modulated by lots of different molecular and neurological pathways. We'll be talking to the neuroscience undergraduates tomorrow. They'll know more about the pathways than I'll be able to explain to you. But this is the system that gets broken in many pain conditions. A variety of triggers will reduce that. Early childhood exposure to trauma, taking opioids long term, ruin the pain system. The amplifier on the electric guitar, it's turned off, you have to really hurt. These are the marathon runners. You really have to stroke that to get pain. As you dial that up, you get to hyper-responsiveness, and if you're unfortunately somebody with fibromyalgia, it's set at 8 or 9 on the amplifier. So a very normal sensation is experienced as painful. These are not made-up conditions. We can see it in functional studies of people's brains, that this is just the unique characteristics of the individual in terms of the response to the same sensory input. So a word on adverse childhood experiences. This is critical to understanding the development and evolution of pain in our patients. On the left, you can read it yourself. Basically, growing up in an awful environment, abuse, incarceration in the family, addiction problems in the family, neglect, abandonment, and that correlates, and Bob And has done great work, and there's a whole field of adverse childhood experience literature, leads to people having bad health outcomes, depression, suicide, multiple sexually transmitted illnesses, smoking, alcoholism, social and cognitive impairments, disease, disability, and social problems, but it also highly associates with chronic pain. In our pain clinic at the University of Washington, well over 30% of our patients have post-traumatic stress disorder from adverse childhood experiences, and 90% of them weren't recognized as having it. So we have to make the diagnosis, as I was telling the students. You have to understand what is going on in the brain and the top-down modulation to understand it. And this is Karen Davis's work, which pre-existing brain states impact the experience of pain. That's asking a 1 to 10 question, how much it hurts, or being exposed to a painful sensation and being told it's going to persist, and been re-exposed to that pain sensation without the original one going. We've done an optical illusion on our brain. We've tricked our brain to think we're going to hurt more, and we do hurt more. And the activity in the brain, the sites that recognize pain as an adverse signal, become activated as a result of the anticipation and the expectation of setting pain. We'll get into this in a bit further. So Muhammad Yunus in 2007, I heard him lecture in 1995. He's a fibromyalgia doctor at the University of Illinois. He said fibromyalgia is a system of a pain processing disorder. And I had gone through medical school. I was in practice quite a number of years already. And I said, finally, someone is describing what I'm seeing. He did breakthrough work. And you can see, and I'm going to highlight here, there are probably people in the room suffering from one or more of these conditions. I'm not asking anyone to identify because there's privacy involved in our health matters. But these are the most common conditions our primary care workforce sees. These are all related to fibromyalgia sensitivity. This is the amplifier and the electric amp turned up. And we know the things that reduce that signal and that response do not include opioids. So if you have any of these conditions, or your patients have any of these conditions, you're making them worse, unfortunately. These do not involve the bottom-up signals. And our management of this has been revolutionized. Eunice has done this work, and there's a lot of this work going on across the nation, including in our health system. So I'm going to go back in time. I was a philosophy undergraduate. I love to quote the great poets of the world. I think you got it. The sorrow which has no vent in tears may make other organs weep. This has been recognized historically, that if you have no other way to deal with these early traumas and the abandonment, neglect, and failed surgeries, 2 back surgeries, 15% incidence of post-traumatic stress disorder. ICU stay longer than 3 days. Repeating a surgical procedure for which you had a bad outcome and having the same bad outcome a second time. PTSD starts to activate. The same circuits activate, and the sorrow that we have with the loss and the frustrations and our unmet expectations will sensitize all our organs to experience pain at an abnormal level. So let's learn a little bit more about how opioids fit into this. So if you look at the effectiveness of opioids, you can see that there's no long-term evidence of benefits. I'll talk about this a bit more. But at best, across populations, about a 30% reduction in that pain intensity score, which I already told you is hard to interpret. But nonetheless, this is what the data shows. And non-opioid drugs, the antidepressant categories, the anti-epilepsy categories of drugs, work about the same. So we get about a 30% general improvement. It takes about 4 to 6 people to even see a 50% response in pain. So we're not very good at managing them with drugs, and it's not a surprise to anyone that putting a little molecule on another receptor is going to change the way the whole body experiences something as complicated as pain. Now on the right side are the non-pharmacological strategies. And I've given you some pictures to give you an idea of what this looks like. Acupuncture, better sleep, cognitive behavioral therapy, which is a recognition of what your negative thoughts are and the negative behaviors that may respond. Mindfulness, just studied in collaboration with Kaiser in Seattle and our faculty, University of Washington, Dr. Judy Turner, did a mindfulness training program for chronic low back pain. And they were not given any opportunities to be on opioids in this study. They had a 50% reduction in pain. We don't have any other agent that's as powerful. I understand that. I'm hoping my description of how much our brain is anticipating and expecting pain is going to drive this. And I will give you my home phone number if you're going to call me anytime, day or night, if you get a report of an overdose of mindfulness. Because it's yet to be reported in the overall literature. But you can read through the rest of these. Yoga, I just had a great success in my clinic with a tough guy, mountain biker, skier, hang glider, I mean, all these things that would terrify me. Young, strapping 35-year-old, 2 young kids, has a farm. One of the upstanding citizens, he came into the office on massive doses of opiates and sedatives, completely disabled by the problem. We had a nice chat. His pain scale was 10 over 10, not surprisingly. Everything was 10 over 10 that I asked him in terms of misery. And we talked a little bit about yoga, and he said, me do yoga? And I'd explain it to him, and the disclosure here is I don't do yoga. My wife can't believe I talk about it if I don't do it. I've explained to her that I don't have to have a bypass surgery for cardiovascular disease and be able to talk about it. So he went off and came back, and he was transformed. He said, instead of fighting my body, I became comfortable in it. Best description. And I asked him to reduce his dose. He was 80% dose reduction voluntarily. I said, we'll talk about it. He just did it. He began to feel comfortable in his own body. Turns out he had a lot of adverse childhood experiences. He had an alcoholic father. He used to beat him. He used to be not allowed in the house to eat if he didn't get the chores done. And he would grub food at his neighbors' homes because that was how you get tough. Go find your own way. This is not a way to parent, and this set himself up to not be comfortable in his own body. Actually, Maudsley got it in the 19th century, and I think we should be able to understand this as well. So how should we best treat the different kinds of chronic pain? Well, cognitive and behavioral. I've listed some of the characteristics of the cognitive side and then the behavioral side, and you put them together and you get cognitive behavioral therapies. Physical activity. The miracle drug is exercise. All conditions improve, from a sprained ankle to Alzheimer's, from cardiovascular disease to hypertension to diabetes and chronic pain. And if it hurts too much to move and get any activity, you're turning the amplifier up on your pain system. And there's multiple strategies to be able to manage that. Spiritual. This isn't necessarily faith-based spiritual. It's just identifying something bigger than yourself. Viktor Frankl wrote a wonderful book, and the prisoners in the Nazi prison camps, those who at sunset, when they looked up at the sun setting and the beautiful visions of the colored sky, they had no shoes, it was sub-zero, they were building railroads, and their feet were so swollen from edema and their skin was cracked. They would look up, the ones who looked up at the sky, it took a moment, they survived the camps. He introduced logotherapy, the standard therapy for management of cancer-related pain in Sloan Kettering right now, in terms of what's the purpose of my life. And if you have no meaning and purpose in your life, you're in a severely distressed socioeconomic area and you have no opportunities to be the person you are, a reduction in your capacities, that's called suffering, that's interpreted as pain, and your pain sensations are increased. That's why we have a chaplain at Harborview, our county hospital, a trauma center. If people come in and they just are hopelessly despairing, we identify that they don't have any meaning and purpose in life, they get a chaplain to talk with them and introduce that. And we have some preliminary data showing 20 to 40% reduction in opioid use in the trauma population by someone just talking with them. So we believe rubs and hugs work better than drugs, even in those most traumatic settings. And then education, I talked already about how important it is for our practitioners to understand this, certainly for our patients to be able to reset expectations about what pain means to them, what the sensation's about, and be able to promote self-management. The first pain clinic in the world I mentioned started at the University of Washington, and we took patients, because I was there in the mid stages of its glory days, we took patients off every drug they were on. We put blind cocktails, we took them off, and we gave all these other modalities, and they got enormously better. We told them at the end they were drinking a blind cocktail of nothing, a little bit of hydroxyzine, so it had bitterness that would mask the taste. And they were dramatically improved. And then on the way out the door, we'd ask them, so how bad is your pain? And they go, oh, what? No, that's right, I have pain. Well, it's a 10. Pain salience. I didn't understand it at the time. We don't ask the question. We shouldn't walk into the exam room with a patient and say, so how, Mr. Smith, how's your pain doing? Of course it's going to be worse. We've drawn attention to it. Hear the fan in the room? Do you feel your rear end sitting on the seat? Only if you call your attention to it. Our body extinguishes sensations that are not important. If pain is the most important thing, and seeking pain relief is the most important thing, you're going to have more pain. You need to get past that. You need to look beyond that sensation, and you can actually establish dramatic improvement in rehabilitation. All right, now the dark side. When pain management goes wrong and we decide that we're going to cure all this by doling out medications, we see a lot of drug addiction. We think about 30% of people on opioids for chronic pain meet the criteria for opiate use disorder. In my training years, we were told that it was less than 1%. A letter to the editor in New England Journal from a case review that wouldn't even have met the test for submission as an article got published. And Herschel Porter said, I wish I never wrote that article, because that said, well, you won't get addicted if you take opioids. Didn't turn out to be the case. The definition is the 3 C's for trainees or people who are interested, what the quick version of it: can't control, crave it, and do it compulsively. And the DSM-5 has a lot more determinants to characterize that, but this is the simple way of remembering that these behaviors are addictive behaviors. It applies not only to opioids, but to tobacco, to alcohol, to gambling, et cetera. And addiction is a brain disease. It's a neurobiological disorder. It is not a personality disorder or a failure of character. It's a neurobiological disorder. And the stigmatization of pain, having chronic pain, and being a chronic pain patient that no one wants to get close to, applies the same thing to people with addiction disorders. And the humanity that we need to show all our fellow humans, and certainly clinicians need to show their patients, needs to apply to both these stigmatized populations. So why on earth would opioids that are pain relievers cause addiction? Well, the first is on the graph here. This is a courtesy of Dr. Jane Ballantyne, also on our faculty, an international expert. I've learned more from her than not quite John Lozier, but one of my great mentors as well. Speaks about, demonstrates that the taking of an opioid gives a euphoria, and it's a pain relief initially. And when that wears off, you need a little bit more the next time. Pretty soon you can see the shape of the curve. It goes from pain relief and feeling good to feeling normal. So you need the agent just to feel normal. And if you keep at it, you can't even feel normal, as the curve dips below that, and you have to be at peak doses to feel normal. And this happens through a very complicated mechanism. I've given you a sketch here of the reward system, the pain system, the development of tolerance, relieving stress, and the challenge of integrating rewards and dependence and pain relief with this molecule turns out to be very, very difficult, and we need a better molecule that can manage this. And opioids also not in this, and Dr. Ballantyne and Dr. Mark Sullivan also in our program have identified that one of the biggest hazards of taking opioids is it creates social isolation. It knocks out our ability to connect to other people. It's been well described. And our patients, when we take them off opiates, will say, I don't feel like a zombie anymore. And the family members will say, he, she, mother, sister, father, brother, whatever caregiver comes in with the patient, they don't act like a zombie anymore. So fortunately, my son was very much into zombies when he was going through his high school and college years. I know all about the zombie madness. And what makes a zombie a zombie? Some creature that doesn't connect to other people. So we've anesthetized our patients because we use opiates and benzodiazepines in the operating room. And we give them high and high doses to make the tolerance and to keep the sensation of pain relief coming. We use these drugs in the operating room with an anesthesiologist standing by, heart monitoring, a ventilator, breathing for them. And we give these same drugs to patients in the wild without any expert standing by their side. It's no wonder they're dying. In Washington State, in 1999, the law changed. The under-treatment of pain, we need to use opioids without restrictions. This is a terrible mistake. Mea culpa, I was part of the group that thought this was fine. I think the key words is quantity and frequency. And we also didn't put for proper indication. Now we know, and the new rules are going to come out, and they are coming out, that there ought to be disciplinary action if you're practicing outside the standard of care with such a risky drug. But this set the floodgates, and this happened across the country. Nearly all the states had an intractable pain act in response to the under-treatment and the fear. 80% of global opiates are consumed in the United States. 98% of all the hydrocodone is consumed by Americans. There's enough oxycodone distributed in America right now by pill count that you can have a bottle of 30 every American, and that includes infants and children. There's so much out there, and you can see the US on the right, that's the bottom line on that graph, compared to the rest of the world, including high advanced societies, European and other countries that pay a lot of attention to healthcare and have the resources to management, the first world countries. You can see we outstrip that. So we have a unique American problem with our opioids. And this over-reliance on opioids for pain management has been costing us $650 billion a year. The cost that exceeds cancer, diabetes, cardiovascular disease costs. This is managing pain poorly. I've heard experts say that's about 10%, 20% wasted. I will state publicly, I think 70% of that money is wasted from what I've seen in practice. So if we take 70% of that down, look at all the good we can do with the billions of dollars for the other management that we've not been able to deliver across the board. 16,000 people die from prescription drug overdoses. 500,000 people come to US. This is on an annual basis. This is why it's called an epidemic. It's also called an epidemic because it's the third largest epidemic in American history. The largest is the flu pandemic, 1918. The second was HIV, which killed over 500,000 Americans. Terrible disaster. We're working on that number. Between 1999 and 2014, it's now almost 200,000. The numbers are going up, not going down. And in fact, the peak death rates during the HIV epidemic are exceeded now by opiate overdoses in this country currently. So calling it an epidemic, it's a health issue, it's health behaviors, it's healthcare involved, so it's therefore an epidemic. So one of the players in this are the pharmaceutical promotion. I don't want to spend too much time on that, but Purdue, which is being called out, and I understand that Spokane County is jumping into the lawsuit with class action activity against the main manufacturers. They were shelling out about $200,000, excuse me, yeah, $200,000 a year to pay for representatives to go to the clinician's office and to promote the drug and say it's not an addicting product. You can see the response to that. It went up from 670,000 prescriptions to 6.2 million, a tenfold increase in number of prescriptions. By 2004, it was the most prevalent opioid that was being abused. And in 2007, the same year that I and the Agency Medical Director Group and Washington State Department of Health was sued for depriving opioids to people who needed it, they were fined $634 million for promoting the product. The bitter irony to that. And if you look at the return on investment, they made in that same interval $35 billion. So that's a 55.6, if you do the math right, return on investment, and that is a heck of a company to be working with. So they and others are branded. There's a complicated system, prescribers, lack of system resources, lack of education. There's a lot of guilty parties on all this. But you can see the impact on the United States, the heat map. To top this is 2003. And you can see this epidemic swept America. And you can see us in that lonely northwest corner. Beautiful, not terribly polluted, wonderful people. We are also significantly affected as well. Here's most recent data from the Washington State, what's happening in this state. So the dark green is the highest opiate overdose rates. The gray is the lowest. The pale green is the intermediate. That means between 10 and 14 people per 100,000 are dying of opiate overdose deaths. This is by county. And if we just kind of separate the west from the east by the Cascades, you can see it's sort of the same, but rural areas in some portions, particularly in the peninsula, are having a much higher impact, and that's a complicated problem that involves socioeconomic opportunities, access to non-pharmacological strategies. So it continues to be a problem right here in River City, I guess. It's not called, is Spokane River City? No? Is that? Yeah, it ought to be. Reminds me, how about the fatal heroin overdoses? Since 4 out of 5 heroin users will report that they use prescription opioids before they got hooked on the heroin problem. And you can see there's a pretty hot area involves Spokane County and just north in terms of heroin overdoses. And again, the darker the color, the more overdoses. The slash lines mean we don't have enough good quality public health data for them to report it as such. In Washington State in 2007, when we were sued for releasing these educational guidelines, you can see that's mapped by that little picture on the left. We actually bent the curve, which is great. And since then there was the law that came out, and it has a significant impact on the number of prescription opioid deaths in the state. So we're busy patting ourselves on the back, and experts in the addiction field, Caleb Banner-Green, a great colleague of ours in the Alcohol and Drug Addiction Institute, is saying, David, you haven't done anything. It's just been replaced by heroin overdoses. You can see the total overdose death in Washington State is not any better. It's substituting one opioid for another. So we need to confront this problem. And it definitely appears that the introduction of prescription opioid experiences clearly have led to this transition into heroin addiction. So being in an educational facility, not this room, but surrounded by educators, Naloxone 101. This is something for patients as well. It reverses overdoses. It blocks the respiratory suppression associated with that. So all patients on chronic opioids, certainly at higher doses, should have one on hand. Someone else, they're going to be asleep and unarousable, needs to be available to offer that. So family members, and if you don't have a family, you can't be taking it, unfortunately. First responders, it only lasts 30 minutes, so you better call 911. So this is basic principle, and this is in all the guidelines in terms of having this available. But before you get to that, we want to be able to treat opiate use disorder. Opiate use disorder is the politically correct, polite way of describing addiction because it's specific to the disease, and it describes it as a disorder, which is what it is. So there's 3 standard treatments. The top 2 you may have heard of: methadone maintenance, buprenorphine. I'm giving the brand name Suboxone because it's basically known, and naltrexone is a blocker, and it can be used as an injection or an oral tablet. Turns out that abstinence only doesn't seem to work because it's a chronic neurobiological disorder, as we learn, and it just doesn't go away by wishing it away. The 12-step model does not appear to work. It would be great if we could accomplish that. So using these drugs are designed to replace the awfulness of IV or injection drug use and the complications that are associated with the ravished lives of people who are participating in methadone maintenance, buprenorphine, are receiving concurrent behavioral health and opiate use disorder support. So why do we like opiates so much? Well, they make patients happy, the happy plant from the Sumerians. You can get a pharmacy in every small town in America, but you sure can't get someone who understands pain, or a cognitive behavioral therapist, or a physical therapist who understands pain. So even in the remote sites, you can pick up those opiate drugs. Insurance, paradoxically, covers them better than any other treatment. A month of OxyContin in the old days would pay enough for the full behavioral health support for your patient, full round of cognitive behavioral therapy, which we learned has 1 year sustainability, durability in terms of treatment. And yet we're willing to spend, and insurance companies are now coming around when they realize the value proposition of treating pain from a behavioral, cognitive, physical, mindfulness approach is certainly the way to go. And for the clinicians, in the old days, I had a prescription pad in my pocket. The good old days when I didn't have to fight with the computer. Someone is out there and recognize. I used to pull the pad out of my pocket, and the whole visit was relaxed. They get in the meds, I'm finished the visit, we can move on, I'm running an hour late already, I can close the visit. So it was the most convenient strategy for clinicians. So I play a role in having contributed to this problem. But these are the odds that are stacked up against us. So risks and benefits is what we do as doctors, the Hippocratic Oath, above all, do no harm. So if the harms exceed the benefits, we should be offering that treatment. And this 2015, so this is almost hot off the press, I had an opportunity to participate with this group, and we concluded that based on the evidence collected, there is scant evidence that opiates for chronic pain are effective overall, and clear evidence of risk. And this drove the Centers for Disease Control to take our guidelines and put them into national guidelines. And we're real proud to know that we were leaders in this area. So when do we need opioids? One of the medical students would say, isn't there a use for opioids? And I said, absolutely. They're a gift if you have an acute traumatic injury. Those soldiers, when they asked for it, they got it. When you go through the hospital and have a surgical procedure, and you wake up with acute physical trauma, those nociceptions are really, it doesn't matter where the volume is turned, they're on, and the brain is telling you that there's been something bad to your body. So they're very appropriate for acute pain, for perioperative pain, pain that follows surgical procedure, from cancer-related pain, because many cancers, certainly in active stage, but even after effective treatment, have ravaged the tissue such that the injury just is not going to recover like we would expect with most injuries, and certainly at the end of life, in palliative care and in hospice services. But again, there's no study of opioid versus placebo, no opioid therapy or non-opioid therapy evaluated for more than a year that showed any improvement in pain, function, or quality of life. Nice study done in Denmark demonstrated the higher the dose, the longer the period of time, the worse the pain, the worse the function, and the worse the quality of life. So what are we doing? We're trying to change the direction of care. So next gen, I asked, does next gen refer to next generation medicine, or is it the next generation of physicians who are training? They get it. They're astonished. What you were doing? What? Really? What were you thinking? I love it. It's great to hear those fresh minds calling us out, because really, what were we doing? So what's our systems? I'm going to try to wrap it up quickly here because I want to have time for questions. We want to identify the system-wide obstacles. We don't have enough time. The primary care doc is 15 minutes, 7 chronic illnesses at the same time, 7 preventative maintenance things that you get scored on if you don't do. Each one of those takes 7 minutes, so we're already at 30 minutes if we start adding them up. By the time you're done, you have no time for pain. Nice article, Got No Time for Pain, named after the Carly Simon song. Indeed, there is no time. So the workflow does not exist for our primary care workforce to be able to manage that. Not enough pain-trained non-physicians, behavioral health specialists, physical therapists, patients and family educators. Who's going to explain to the patients the things that I'm talking about right now in this crazy workflow? Who's going to pay for these individuals? Who's going to reimburse for the time? You know, we got to give a living wage to all the people who work in the health system. And there's still financial incentives to do stuff. Doing stuff means an injection, a surgery, a drug. And drugs and procedures are covered better. And usually there's no coverage for the stuff that works. So we got our work to do, and I can tell you there's a lot of good people around the whole country. Certainly, we're very involved at the University of Washington, working on system changes. We need to reduce the over-reliance on opiates for acute pain. Exposure matters. 3 days is almost certainly enough for most acute traumatic injuries. 1 to 2 weeks is plenty for nearly all trauma and surgery. This is based on good data that's being collected nationally for how many pills people use. Most people take 10% of the prescription that's given. A nice study showed if someone going in for a total joint replacement after a previous one, say, I don't even need any opiates. They don't have to give me a prescription. I have so much left over from the last prescription. At 6 weeks, the brain has changed, the spinal cord has changed. You're transitioning into chronic. And at 12 weeks, if you're on opiates for 12 weeks, there's a 65% chance you're going to be opiates for the rest of your life. That's eye-opening. It opens our trainees' eyes, and we need to be able to tell our patients, I'm getting you down. It's not because I'm following rules, because I'm trying to do the best I can as your provider. So quick quiz. What's the average pill count for a new prescription for a youngster, 14 to 19 years old, with no prior opiate prescription? Average pill count, 24 tablets. What are we doing exposing these kids to opioids? What's the range of opiate pills dispensed for acute pain by different primary care, medical, and surgery specialists? Between 20 and 150 tablets on the original prescription. So there's way crazy variation going on in this that tells us we don't really have the answer correct. And what's the range of opiates following elective surgery? I give you a hint. The recommended number is 30. The answer is 0 to 200 tablets. So we need to get our house in order. But you as the consumer needs to say, how many pills? Why don't you give me 5? Why don't you give me 10? I don't think I need that many pills sitting around to possibly lead to a problem. And dose matters. The guidelines talk about between 50 and 90 morphine equivalent dose. Don't worry about it if you're not a clinician to interpret this. This is based on good data, that at over 100 milligram dose, there's a 900% 100% increase in an overdose event. And the point of deflection looks to be about 50. And I got to say, our colleagues at Group Health Kaiser Permanente, the Dunn study in collaboration with the University of Washington, produced the first data that demonstrated that dose matters in terms of health outcomes. And we need to pay attention to health conditions. For instance, breathing, sleep apnea, fairly common, central sleep apnea even more common in people who are on opioids, chronic asthma, emphysema, bronchitis. Since opiates suppress breathing rate, it's not a good idea to give them to patients who already have breathing problems. Taking opiates with other drugs, taking other drugs with opiates, such as sedatives, like the benzodiazepines, and alcohol. Most opiate overdoses are recorded with alcohol intake concurrent with the opioids. And not taking as prescribed. Well, a few, I'll take a handful. That's what's killing our patients. And if they don't have a handful to take, it's much less likely. And if they get educated, most people really want to do well. These are, people with chronic pain are not trying to ruin their lives and the lives of others. They're just struggling to find a system that can support them and allow them to rehabilitate. So on the left are our guidelines, and on the right are the CDC guidelines. And I'm showing this to this audience because most importantly for patients and families is a checklist for what you should be doing when you pick up opiates and how you should use the checklist. Atal Gawande, the famous checklist guy, took the airplane pilot checklist, introduced it in medicine. He built this checklist that's available, and it's a checklist for prescribers. So it's out there now. This came out in the past year. So we are turning the tide. We're working with a group and I show my colleagues at Kaiser Permanente, our Rural Health Research Institute in the WAMI region, and some of our translational informatics people are working on leadership at the clinic level, clinic directors. Top level has to be on board. You need to know who is the problem in your patient. You have to change your workflow in the clinic. You have to be prepared for these complicated circumstances, so you make the time, find the time, and focus the visit and conversation. You have to recognize that complex challenges require complex treatment plans that require a multidisciplinary team, and then you got to track your success. So we've launched this problem, and one of the gentlemen I met last night at our other meeting, the CME activity, was engaged in actually this research, and he came up to me and said this was fabulous. The problem, he's not getting leadership support. So we're going to talk about how to solve that particular problem. So it's understanding the goals of chronic pain management. It's not enough to relieve symptoms. Function is the most important thing. That dictates quality of life. Skills and attitudes have to be relearned, and social interactions need to be facilitated. Opiate as a sole treatment for chronic pain will fail. Occasionally it works, and at low dose, and for the proper indication. And my colleague, John Lozier, my mentor, palliation without rehabilitation to a patient with chronic pain and a normal life expectancy is a dangerous clinical, economic, and ethical decision. So it is complex. But your healthcare providers get this. They're well-trained. They understand complex decision-making. That's why they get into UW Medical School. They understand how to do this, and we're going to train them right. So what you can do, learn as much about your pain condition, set reasonable expectations, and remain motivated. Self-management, I put essential, and I was going to wipe it out. It's crucial, and I left essential in because it's more than essential. It is the determinant about whether you will be able to manage your chronic pain most successfully. I've reviewed a couple of strategies there, and of course, take medications only as prescribed, and don't share them because a leading cause of opioid overdose in youngsters is taking pills that are left over from the medicine cabinet. And all you have to do is click a button. If you're a clinician in your office now, and you as a patient just have to go on this site, you look up Department of Justice, safe disposal, and they will tell you the nearest by zip code where you can get your pills disposed of, and they don't necessarily have to get flushed down the toilet. So closing remarks. Francis Peabody, a surgeon at man's greatest hospital, Mass General Hospital in Boston. Having come from Boston, that was conversations we used to have there. But the comment is the secret of the care for the patient is in caring for the patient. Now, who does that not resonate with in this room? Please excuse yourself, because this is the principle of being a healer, is caring for the people. And if you stigmatize the patient, you're not caring. If you don't want to treat this disorder, you're not caring. If you don't have the patience to listen to it, if you don't fix your health system, If you don't work with your own family and your own self, you're not properly taking care of your patient, and there's no drug that's going to solve that. And as John has said repeatedly, chronic pain is not a state of opioid deficiency. So on those words, we do have time for questions.